Hi, my name is Mohammad Iskandar Ali. Today we are going to learn how to examine the knee. So we have got Mizan with us. We get you to start by just doing some walking. So we are looking at gait, looking to see if he has any problems walking and where there is any evidence of intelligent gait. And he is obviously walking fairly comfortably. The next thing I like to do in standing is get the athlete to do a squat on one leg, a single leg even. So if we get you on leg, then we are gonna get you to squat up and down. So the things I'm looking at from the front is he is able to keep his pelvis nice and level, and is his knee hitting, is his knee able to stay nice and lined up over his foot, which is desirable. The rest of the test we'll do in lying position. Have a look to see if there is any obvious swelling or scars or skin changes. I like to pick up his heels and see whether his knees will drop into normal extension, where there is a block to extension or any pain with that. And you can see that they are both very symmetric there. Then we are going to examine Mizan's right knee here. I like to bend the knee up to 90 degrees comfortable in that position, and so this is the best position I think to palpate the major landmarks around the knee. So I start at the medial femoral condyle, so that's where the medial ligament attaches, and over that the spot can be tender when someone injures their medial ligament. Then I drop down on the medial joint space and palpate the medial joint line. There's generally tender as someone has a meniscal tear or a chondral defect in the medial compartment. A useful technique is to use your thigh to support the femur. So want to explain what we're doing, Mizan. Do you mind if I put your leg under your leg? So we have got nice control over there. The thigh sitting comfortably on my leg. Patient usually feels more comfortable with the knee flexed a little bit, and we do the same sort of movement if someone's injured their anterior cruciate ligament. There is also another test called a pivot shift test, which sometimes is pretty difficult to do when the athlete's knee is sore, as more easily done under aesthetic, but is still worth trying to do. And basically the test tries to replicate the sensational feeling that the athlete has when they tear their ACL. So to this test, we take the heel, put the leg into internal rotation, apply a valgus stress, and we take the knee from a position or full extension up into flexion. So internal tibial rotation, valgus stress, extension, deflection, and that should reproduce a clunking, disconcerting feeling that is sometimes like that the patient felt when they ruptured their ACL. The next ligament test we are going to do is an anterior draw or posterior draw test. So we are bending out of 90 degrees again. We have to get the patient's permission. I am going to sit in your foot. So sit on your foot, and what I am going to do is pull first anteriorly and then posteriorly. So anteriorly solid and point, no laxity there. Posterior drawer, looking at the PCL, very solid, no laxity, no pain. If we think the patient may have a PCL injury, we can do a different test looking for a posterior sag. So you flex both knees up so they are sitting next to each other, and we have a look at the tibial tubercles to see whether they are sitting at the same level. If a patient's injured their PCL, we may see one of the tubules sitting more posteriorly related to their normal or contralateral side. Having done that, we are now going to move on to some minuscule tests. So the premise or basis for all these tests is, can we capture the injured meniscal between a flexed thigh and the tibia? So any sort of test that has a degree of knee flexion and rotation can aggravate the meniscus. So one test is to palpate the joint line, have your fingers on the medial and lateral joint line, and to simply just tibia rotate the tibia. So internal and external rotation, and seeing whether that aggravate the patient's pain. My tests involve full flexion, valgus and rotation, or full flexion, internal rotation, and various force moving from flexion. Now we look for patellofemoral dysfunction or patellofemoral pain, and it's quite a difficult diagnosis sometimes because the pain is very vague and non-specific. So a test where we compress the patellofemoral joint can be quite a useful thing. So we basically apply a downwards or a compressive force through the patella with our thumbs as we gently flex and extend the knee, and we are seeing whether it produces any of the patient's pain or problem. So is that provocating thing? We're going to roll onto his tummy into a prone position, and they're lying prone. We can inspect the popliteal fossa looking to see if there is any swelling. So is there a bucket cyst? Is there any obvious asymmetry between the two? And there are two tests that are worth considering in prone. So the first one is the green test. Is a minuscule test. We stabilize the femur, apply an axial load through the heel and through the lower leg, and we move the leg into external and internal rotation, seeing whether it aggravates the patient's symptom. So these are very sensitive or low sensitive tests. The final test is to have a look at this dial test. So this is a useful test if someone's had a more significant injury and you think they may have injured post-lateral corner structures in the knee. So we take both feet, flex to about 30 degrees, and then externally rotate those feet. So we are looking for any asymmetry, and if there is an increase in external rotation of more than 10 degrees, then you think that there may be isolated postural lateral corner injury. If you take the knees up to 90 degrees and there is an increase in laxity in this position, we are thinking that there might be isolated post lateral corner injury and a post. That's how I examine the knee. Thank you.